Hello everyone, in this video we will talk about drugs for Parkinsonism, and like all pharma videos, the video notes of this lecture will be available for free download from the app. So before we proceed to the drugs for Parkinsonism, simple basal ganglia circuit we will see, not in detail, very simple. That basal ganglia consists of certain nuclei, that is striatum and there is globus pallidus. Via these, by two pathways, that is direct pathway and indirect pathway, information reaches to the thalamus, and thalamus in turn excites the cortex. So cortex is sending information to striatum, and from striatum information going to thalamus, and from there excitation of the cortex. Basically we can say it is a checkpoint for the start of the movement. Okay, so when cortex wants to initiate a movement, it sends the information to the basal ganglia, and direct pathway facilitates movement. Okay, direct pathway facilitates movement. On the other hand, indirect pathway, when it is activated, it inhibits movement. So this start and stop of the movement is brought about by basal ganglia. Now, dopamine is very important in this. Okay, so dopamine is released from substantia nigra pars compacta, nucleus of the basal ganglia, and dopamine, you see, excites the striatum. It basically acts on D1 receptor present in the direct pathway, and dopamine acts on D2 receptor present in the indirect pathway. Okay, so dopamine excites the direct pathway but inhibits the indirect pathway via D2 receptor. So I told you direct pathway facilitates movement and dopamine is exciting this direct pathway. So dopamine facilitates movement and indirect pathway inhibits movement. So dopamine is inhibiting this indirect pathway. So again dopamine, by basically exciting direct pathway and inhibiting indirect pathway, dopamine overall it is facilitating the movement. Okay, now in Parkinsonism, major problem is loss of this substantia nigra pars compacta dopaminergic neurons, right? So if dopamine is not present, what will happen to movement? There will be problem in the initiation of the movement. So we have different features of Parkinsonism, that is akinesia, person is not able to initiate the movement; bradykinesia, slowness of the movement; rigidity. Okay, so there is lead pipe rigidity. Then person also has resting tremors. Then shuffling gait, again shuffling gait because the person is having very slow movements, he is not able to move fast, very small steps will be there. There is loss of associated movements. For example, when he is walking, the associated movements include hand movements, so that are not going to occur. Mask like faces, because spontaneous movements which occur in the body, in this case like facial features, there will be no contraction of these facial muscles, so that is mask like faces. Now, for the treatment of Parkinsonism, we have two strategies. We have said that dopamine is decreasing because of the loss of the dopaminergic neurons. So, one strategy is to increase the dopamine levels or increase its action. Second is based on acetylcholine. Actually, when dopamine decreases, there is a relative increase in acetylcholine action, right? So, we want a balance in the basal ganglia regarding dopamine and acetylcholine action. So, acetylcholine is released from some very small neurons in the basal ganglia. We have not discussed that, but yes, when dopamine decreases, relatively, obviously the action of acetylcholine is more than the dopamine. So we want this activity to decrease. So either increase the dopamine levels or its action, or increase the acetylcholine activity. So first we will talk about this strategy and then we will talk about acetylcholine. Now, when we talk about dopamine levels increasing or its action increasing strategy, we have different types of drugs. So, first we'll talk about the mechanism that how dopamine is acting. See, this is the dopaminergic neurons. In this neuron, dopa is getting converted to dopamine by an enzyme dopa decarboxylase. And for this enzyme, B6 is a cofactor. Just remember this fact, we will come back to it later. Okay. So, dopa converted to dopamine by dopa decarboxylase enzyme. Now, this dopamine is released, okay, from the presynaptic neuron, and it acts on the striatal neurons via D1 receptor and D2 receptor. D1 receptor in the direct pathway, D2 receptor in the indirect pathway. Now, after releasing, it should not be there permanently, it should be degraded. So, it is degraded by two different enzymes, either MAO-B or COMT enzyme. So, monoamine oxidase B enzyme, it breaks it down to DOPAC, and COMT breaks it down to 3-MT. Not necessary to remember these degraded products, but here you remember these enzymes because we have drugs which act on these different enzymes. Okay, now dopamine, I told you, it acts on the dopamine receptor. So what are the various strategies? First strategy, increase the dopamine levels. Okay, directly give dopamine analog. Now remember, we don't give dopamine directly as such because it cannot cross the blood-brain barrier. So we give an analog which can easily cross the blood-brain barrier. Okay, so that is first. Second is that when you give this dopamine analog, you should ensure that it is going into the brain. It should not be degraded within the circulation. So in circulation also we have this dopa decarboxylase enzyme. So that will break down the analog which you have given. So we can use a peripheral dopa decarboxylase inhibitor. That is second. Third include dopamine receptor agonists. So we just give the drug which are going to stimulate these D1 and D2 receptors directly. No need of these dopaminergic neurons at all. We are giving the drug which are stimulating these receptors directly. Fourth, inhibit the enzyme MAO-B. Fifth, inhibit the enzyme COMT, because if you are inhibiting these enzymes, that means the dopamine levels will be maintained for a longer time, because these enzymes, when you inhibit them, the degradation of dopamine will be less, right? So dopamine levels are going to rise. Then we have the NMDA antagonist. This drug increases the presynaptic release of dopamine. So whatever dopamine is present in the vesicles, they will be released more. That is NMDA antagonist. Okay, so that was the fundamental basis of the action of various drugs. Now moving on to individual drugs. So first drug is levodopa. Levodopa, I told you, it is an analog of dopa. So we give the drug levodopa. Now this levodopa, when in circulation, it is given orally, so it will be absorbed from GIT, and when in circulation, it will be degraded by enzyme dopa decarboxylase in the circulation to dopamine, and it will be degraded by COMT enzyme also. Okay, but very small amount. In fact, 99% of it is degraded in the circulation. Only 1% crosses the blood-brain barrier by certain transporters. Okay, so this crosses the blood-brain barrier, and in the basal ganglia it is picked up by the neurons. Now I am telling that these dopaminergic neurons are getting destroyed in Parkinsonism. So whatever remaining neurons are there, they will pick up this levodopa, and that will be converted to dopamine by means of dopa decarboxylase enzyme. So by giving levodopa, you are increasing the dopamine levels, which is going to act in the direct and indirect pathway, right? Now, because of this metabolism in circulation and also its central action, because central dopamine levels are there, we have certain effects. One will be obviously the action of the levodopa. That is because dopamine is being produced in the brain, right? So because of this, all symptoms of Parkinsonism resolve except resting tremor. Resting tremor responds least to levodopa. Okay, that is one important point, and it comes as MCQ as well. But because levodopa is being destroyed in the circulation and dopamine is produced within the circulation also, we have certain peripheral side effects of this dopamine. Okay, so one peripheral side effect is peripheral vasodilation, and this peripheral vasodilation leads to postural hypotension. Now this dopamine actually can stimulate various receptors in the periphery, and because of that stimulation of the various receptors, we are getting this peripheral side effects. Okay, so there is postural hypotension. Then it can also stimulate the beta 1 receptors in the heart, and this can lead to angina and arrhythmia. It also stimulates the chemoreceptor trigger zone. This chemoreceptor trigger zone, it is present in medulla and it is outside the blood-brain barrier. So this is the area which basically detects the presence of certain chemicals in blood which can stimulate the nausea and vomiting, a sign of toxicity basically in blood, right? So with dopamine, this D2 receptors in chemoreceptor trigger zone is also stimulated, causing nausea and vomiting. So these side effects occur due to peripheral production of dopamine, right? And remember, these are early side effects. So when we start the therapy, these side effects appear first. So it is recommended start with lesser dose of levodopa. Then these side effects, if they appear, slowly increase the dose, because with time there is tolerance to these side effects. Okay, so start with lesser dose, then with time slowly increase the dose of levodopa, and these are the early side effects. Now, before moving on, certain things you remember, that because this levodopa is being destroyed in the periphery, this is going to decrease the bioavailability of levodopa. That means I told you very small amount only is crossing the blood-brain barrier. Okay, so this is decreasing the bioavailability of levodopa. Why we are discussing it here? That if we give drugs which inhibit this enzyme dopa decarboxylase, what is going to happen? One, peripheral side effects are going to decrease, and second, levodopa availability will increase and more will be able to cross the blood-brain barrier. Okay, so here only understand this concept. Now, because dopamine is being produced in the brain by the levodopa, yes, its action will be there, I told you, but there are certain central side effects as well. Okay, and these effects appear late with therapy. Okay, early side effects due to peripheral production of dopamine, late side effects because of the central increase in the dopamine. So what are these central side effects which appear late with treatment? Now that occur because when dopamine is being produced in the brain, it is not specific to basal ganglia. It will go, this lower levodopa will be taken up by many neurons in the brain, and they will also produce dopamine. So dopamine will act on various areas in the brain. Okay, and this leads to its side effects. So normally in brain we have mesocortical limbic system where dopamine acts. We have in basal ganglia also there might be other movement pathways. So suppose a person wants to flex his hand, that will be improved by dopamine, but the other movement pathways, there also dopamine will also act, right? So that movement pathways will also be stimulated. Then in pituitary, and also there is a medullary pathway for sexual activity. So in mesocortical limbic system, we have various receptors for the dopamine. We have D2, D3 and D4 receptors. Now when these are stimulated, we get behavioral problems. See, it is limbic system. So we will get limbic system problems. So we get behavioral problems, anxiety, depression, hallucination, mania, all features of psychosis. Then in pathways where movement is not needed, right? So you are doing biceps flexion in one hand, but there can be other hand movement as well, because there also dopamine is being released, that are also activated. So there is abnormal movement, and this is known as dyskinesias. Okay, then in pituitary, dopamine actually inhibits the secretion of prolactin. Now when dopamine is given, it is going to act there, it is going to decrease the levels of prolactin, and it is also going to increase the sexual activity. So those are the central side effects, and some side effects you can give drugs so that they can be controlled. In fact, for this psychosis side effects, we give antipsychotic drugs like clozapine. Okay, this we are going to discuss in another video when we talk about the antipsychotic drugs. And this nausea vomiting, you can give domperidone. Okay, so moving on to the next part, that once you are giving levodopa therapy, after 2 to 5 years of therapy, you get certain other problems. See, levodopa is basically given in 3 to 4 divided doses. Now, with time, dopaminergic neurons are going to decrease further. Levodopa is not acting on the pathophysiology of the disease. So, neurons are continuously getting destroyed. So, dopaminergic neurons will get destroyed. Now, suppose you are giving 3 doses, what will happen? Because now the dopaminergic neurons have become much lesser. So, whatever levodopa you give, it will be converted to dopamine by remaining neurons only. So, initially there will be good symptom control, but with time, because the neurons are less, there is decrease in the action of the levodopa. So this is known as wearing off. You see, the control level is decreasing. Okay, but further what happens, that initially there will be good symptom control and later on there will not be any symptom control. Okay, so till the time next dose is given, in between itself the person will be feeling good, movements will be better, and then again there will be no symptom control. Okay, so this is known as on phase when the levodopa acts, and when levodopa doesn't act, that is known as off phase. Okay, so these are the certain problems with levodopa therapy. Now we have certain drugs which can help us in controlling this wearing off and on and off phase, right? So before moving on to that, let us see first what are the interaction of the levodopa drugs. One is vitamin B6. So I told you that vitamin B6 is the cofactor for enzyme dopa decarboxylase. Now we have seen that in periphery, levodopa is getting converted to dopamine. So if vitamin B6 or pyridoxine is given along with levodopa, then it will activate this enzyme further and more levodopa will be converted to dopamine in the periphery itself. So that means there will be much more decreased bioavailability of levodopa. So it will become ineffective. Already only 1% of dose is going into the brain, right? So that is one. Second is dopamine antagonists. So dopamine antagonists, that is antipsychotics, metoclopramide, they prevent the action of levodopa because these are dopamine antagonists. That means they are going to block the receptor of the dopamine, and we want here dopamine to act, right? So dopamine antagonists are not given along with levodopa, prevent action of levodopa. Third, MAO inhibitors. MAO inhibitors, actually this dopamine which is formed, dopamine in the periphery which is formed, that we have not seen. So in the periphery, the dopamine which is formed, it is catabolized again by MAO enzyme, monoamine oxidase enzyme. In periphery, actually it is basically MAO A enzyme, MAO B enzyme, which we are going to see the drug which is there, MAO B inhibitor, that is mostly present in brain. Okay, so this dopamine is metabolized by MAO. Now, when we give MAO A inhibitors along with levodopa, this dopamine is not catabolized, its concentration is going to increase. In fact, other catecholamines like norepinephrine, they are also metabolized by this enzyme. So they will also accumulate and their levels are going to increase. That will lead to hypertensive crisis. Okay, so these are the main levodopa interactions. Now moving on to next class of drugs, that is dopa decarboxylase inhibitors. This include carbidopa and benserazide. Now one thing you remember, that this dopa decarboxylase inhibitor, now they are always given with levodopa, always. Okay, so what they do, this dopa decarboxylase inhibitors, they inhibit this dopa decarboxylase enzyme in the periphery, not in the center, in the periphery. So obviously it is going to increase the bioavailability of levodopa because it is not being metabolized to dopamine. It is going to increase the bioavailability of levodopa, so more of it can enter into the brain, right? So what will be the advantages of this? Once I told you that there is increased bioavailability of levodopa. Second, because dopamine is being formed very less, there will be decrease in peripheral side effects, and because there is increased entry of levodopa into the brain, there is decrease on-off effect. On-off effect we have seen, isn't it? So this was on-off effect, that for some time levodopa is active and then it is not active. Now if you are increasing the levodopa entry into the brain, obviously there will be a decrease on-off effect because levodopa, now more dose, will be able to act for little longer time, right? So that is advantages of giving dopa decarboxylase inhibitors with levodopa. Remember, it is always given except in one condition that we'll shortly talk about. Okay, now certain disadvantages also occur. What are the disadvantages? Because you are increasing dopamine levels in the brain, obviously action is increasing, that we are telling, but central side effects will also increase. That means there will be increased dyskinesias, increase in voluntary movement, and increased behavioral disorders, right? So those are the advantages and disadvantages. So simple, easy to remember, peripheral side effects decreasing, bioavailability of levodopa increasing, and hence central side effects increasing. Now, this combination levodopa plus dopa decarboxylase inhibitors is not used only in one condition, when there is excessive involuntary movement. Okay, so that becomes so problematic for the patient that it is better not to give this carbidopa or the dopa decarboxylase inhibitors. Only in that case we give levodopa alone, right? Then we have third drugs, that is the dopaminergic agonist. So what are these drugs? As the name indicates, dopaminergic agonist, they are going to stimulate the dopamine receptors. Stimulate the dopamine receptors. Okay, so there are two types. One that are derived from ergot and the other is non-ergot derivatives. So ergot derivatives include bromocriptine and pergolide. Pergolide you can remember here, it is ergot derivative. Okay, non-ergot derivative, it is ropinirole and pramipexole. Right, now ergot derivatives are not used now because of high toxicity profile. Pergolide side effects include cardiac valvular fibrosis. This is an MCQ. D2 agonist side effects include digital vasospasm, erythromelalgia. Erythromelalgia is basically, erythro is redness, algia is pain, and mel is for the limbs. So erythromelalgia is excessive burning pain and redness in the limbs. Then also there is retroperitoneal fibrosis. So all these are MCQs. So because of these side effects, ergot derivatives are not used now. Non-ergot derivatives include ropinirole and pramipexole. Now, these are D2, D3 agonists, right? Now, since they are stimulating the D2 and D3 receptors, we have seen D3 receptors are present in the mesolimbic cortical system. In fact, this D3 receptor is present in a nucleus in basal ganglia, that is nucleus accumbens. And this nucleus accumbens is a very important nucleus for limbic system. So if this is stimulated, we will get lot of behavioral side effects. So these include impulsive shopping, betting, gambling, and also increased sexual activity. Then there is also postural hypotension and daytime sleepiness. Daytime sleepiness. So that is a very troublesome side effect for working people, and also you have to tell the patient not to drive because there will be episodes of daytime sleepiness. So what are the uses of these dopaminergic agonists? Very important that it can be given in early Parkinson. So even levodopa carbidopa combination need not be started. We can give this in early Parkinson's disease and also in younger patients. Okay. Why it is being preferred lately? Because some people fear that this levodopa carbidopa combination actually increases the damage to the substantia nigra pars compacta dopaminergic neurons. Why so? Because you see, dopamine which is being metabolized, some product is being produced which basically is causing oxidative damage to the neurons. Okay, even though not much evidence is there, but still some fear is there. So early Parkinson's disease and younger patients, dopaminergic agonist is preferred. Then dopaminergic agonists can also be used to supplement levodopa carbidopa in advanced cases, because you are directly stimulating the dopamine receptors. That means no need of these neurons. Even if the neurons are damaged, these receptors will be stimulated and you will get the effect. So this will smoothen the on-off effect. When levodopa is not active, the off effect can be shut down by this dopaminergic agonist that will directly stimulate the dopamine receptor. So advantage is obviously one, smoothen on-off effect and decrease levodopa dose, because when we are giving this, then direct stimulation of D1, D2 receptors is also there. So that is also there, and this will help reduce the abnormal movements, that is decreased dyskinesias. Okay. Now one point more you remember here, that ropinirole is also used for restless leg syndrome, right? Moving on to the next class of drugs, that is MAO-B inhibitors. So we have seen that dopamine which is being released, it is catabolized by MAO-B and COMT enzyme. So MAO-B inhibitors will inhibit this enzyme and prevent the degradation or decrease the degradation of dopamine, increasing its levels. So what are the drugs in this case? We have selegiline, razagiline and safinamide. Now, first we'll see what is the advantage and disadvantage of using these drugs. So, you are preventing the degradation of dopamine. So, obviously the levels of dopamine are going to increase. So, this will also smoothen the on-off effect, right? Because it will prolong the action. And this MAO-B inhibitor can also be used in early and mild cases. So, whatever neurons are there and some dopamine is being released, that is being prevented from degradation, and hence it will be able to act. So apart from dopamine agonist, we can also use MAO-B inhibitors in early mild cases. But there are certain disadvantages. What will be the disadvantages? Increased central side effects. So increased behavioral problems, increased involuntary movement because of excessive central action of dopamine, and there is also postural hypotension. Now, which drugs to use? I told you 3 drugs are there: selegiline, razagiline and safinamide. Now amongst this, rasagiline is more potent and longer acting, can be given only one time a day. Selegiline, one more problem is there, that it is metabolized in liver to amphetamine, and amphetamine is a stimulant, so it causes insomnia, agitation. So selegiline has these side effects and it is contraindicated because of this stimulant action in convulsive disorders. On the other hand, rasagiline, being more potent, longer acting, can be given only OD. It is also not metabolized to amphetamine, so no side effects like insomnia and agitation, but obviously these central side effects and postural hypertension will be there, right? So that is MAO-B inhibitors, and remember this MAO-B enzyme. MAO-A is in periphery, MAO-B is predominantly in the brain. So that enzyme is being inhibited, okay? Next we have COMT inhibitor. So COMT enzyme is getting inhibited. Now this COMT enzyme, both it is present in periphery as well as in brain. So we have seen that levodopa in periphery is being metabolized to dopa decarboxylase, and it is also being metabolized by COMT enzyme. Now, because you are using levodopa along with dopa decarboxylase inhibitor, this levodopa will be directed more towards this pathway, towards the COMT pathway. That is, more degradation is going to occur via this pathway. So, we can add these COMT inhibitors. Next, dopamine, which is produced in the brain, that is also being metabolized by COMT apart from MAO-B, isn't it? So, we can give COMT inhibitors which blocks these enzymes. So, the drugs include tolcapone and entacapone. Tolcapone inhibits both these enzymes, the periphery also and the central also. Okay, so this tolcapone, it is more potent, longer acting, acts in periphery plus brain, but still it is not preferred. Very important. Why not preferred? Because this tolcapone is toxic to liver. Just remember, toxic to liver. Okay, so which drug is preferred? Entacapone is preferred. Entacapone will block the peripheral COMT enzyme, prevent the degradation of levodopa in periphery. So what will be the advantage? It increases the bioavailability of levodopa and it will prolong the on time, because if bioavailability increases, more central dopamine will be produced. So it will prolong the on time. What will be the disadvantages? Same, because more central dopamine is being produced, increased central side effects. Other side effects also are there, that is diarrhea and yellow-orange discoloration of urine. Okay, so that is the fifth category of drugs, that is COMT inhibitors. Then we have among the dopamine side drugs, the drugs which are basically acting to increase the dopamine level or action. Last drug is NMDA antagonist. This is amantadine, and this drug increases the presynaptic synthesis and release of dopamine. So this is NMDA antagonist, that means it is acting on glutamate NMDA receptor. But here the mechanism of action is different. Okay, so it is just increase in presynaptic synthesis and release of dopamine. Side effects, very characteristic side effects are there, that is libido reticularis. So in this, reticularis basically is net-like pattern. So on the skin there is some net-like pattern, and libido is basically purple color. So purple color net-like pattern appears on the skin, and that occurs due to post-capillary vasoconstriction. Okay, MCQs are asked on this. What is the side effect? Edema of ankles also occurs, and another side effect is insomnia. So that is NMDA antagonist. So with this, we have finished this side treatment strategies, that is drugs which act to increase the dopamine levels or its action. Next we have drugs which act to decrease the acetylcholine activity, and these include the central anticholinergics, which are basically three drugs you should remember: benzhexol, also known as trihexyphenidyl, benztropine and biperidine. Okay, these three drugs can be used, and we have seen that levodopa does not affect resting tremor much, but this central anticholinergics benefit the tremor more. Okay, what are the uses? First, when levodopa is contraindicated. So when is levodopa contraindicated? It is contraindicated in patients of psychosis. See, in psychosis patients, you are giving D2 antagonist. And if you give levodopa, dopamine levels are going to increase, and that is going to increase the psychosis behavior. So levodopa is contraindicated in those patients. So that is one. and second is drug-induced Parkinsonism. So in those cases, actually which drug we are talking about here? Mainly antipsychotics. Antipsychotics block the D2 receptor. So you cannot give these other drugs in these cases because antipsychotics block the action of the dopamine. The dopamine receptors itself are blocked by these antipsychotics. So there is no point of increasing the dopamine levels. So instead we go for other side of the treatment, that is decrease the acetylcholine activity. In fact, central anticholinergics are the drug of choice for drug-induced Parkinsonism. Okay, what will be the side effects? Side effects, first of all, impairment of memory and cognition. See, in Alzheimer's disease, we give anticholinesterase, central anticholinesterase, to increase the acetylcholine activity that benefits in Alzheimer's. Here we are decreasing the effect of acetylcholine, so there will be impairment of memory and cognition. And other side effects are like other anticholinergics, and more important one is urinary retention in elderly. Okay, but like other anticholinergics, other side effects will also be there. Then last aspect I just want to tell here, that there is a drug for relieving severe off episodes. Okay, so suppose very severe off episodes are there where the person has become totally rigid. In that case, apomorphine, which is a non-ergot D2 agonist, it can be given subcutaneously. Then there is a newer drug, istradefylline. Istradefylline is adenosine antagonist. Okay, adenosine receptor antagonist. So this receptor is there, A2AR receptor. Actually, adenosine acts on these receptors, and via action from within the cell, it inhibits the action of dopamine on the D2 receptors. Okay, so if we block this receptor, it will stimulate this D2 action. It will prevent the inhibition of the dopamine action, right? So again, this drug, adenosine receptor antagonist, is used for treatment of off episodes, and it has to be taken orally. Again, disadvantages of this drug include increase in the central side effects because you are increasing the dopamine action. So those were the drugs for Parkinsonism. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.